Good afternoon for all. We are very happy today in Damascus University to have Professor Rodrigo Sanches Cunha from Canada. أهلا وسهلا بكم في كلية طب الأسنان. اليوم في عنا تعاون علمي مع جامعة مانتوبا من كندا. معنا البروفيسور رودريغو سانشيز كونا رح يتكلم عن تصوير المقطع المحوسب في المداواة اللبية من وجهة نظر سريرية Clinical Endodontics, a clinical presentation with scientific evidence about CBCTs. Professor, sorry for interrupting. I wonder if you can start the lecture. We are all honored to have your lecture with us today. Thanks a lot and sorry for that technical problem.
So can I share the screen?
Yeah, you can. Yeah, you can immediately. Yeah, I can see your presentation started. Thanks a lot. On behalf of the Dean and our colleagues, we thank you, Professor, for that participation. Sorry for a little of delay. You can start.
Okay, so let's start talking about Cbct and Endodontics. That's the topic we decided. Thank you very much for having me. For me, it's a pleasure to be here and share this piece of information with you all. So just to speed up a little bit, I just want to make sure that we are all on the same page. There's no conflict of interest regarding this presentation. I don't get paid by any company. Everything that I'm going to be talking to you all is based on my clinical experience and the scientific evidence. I am originally from Brazil, South America. I decided to move to Winnipeg, Canada in 2010. Well, I've been here since then, working strictly with endodontics. I started as a full-time professor at the University of Manitoba, where I stayed as head of the Division of Endodontics for 6 years. And 3 years ago, I decided to go part-time, and I'm now full-time private practice, where I joined my amazing partner, Dr. Simona Bessoon. We build our endodontic clinic here, where we have a study center called the Winnipeg Endodontic Study Group, and where we are more than glad to have you all one day come here and join us for one of our courses where we discuss all these pieces of technologies related to endodontics. If you all take a picture of this QR code, you're going to be immediately directed to our Instagram account, where we also share cases, scientific evidence. We're always discussing endo, so feel free to do that. And this is an amazing tool for us to communicate. This is Winnipeg, Manitoba. We are right in the middle of Canada. It's right in the middle. Winnipeg is a city of around 800,000 people. I have many Syrian friends, amazing people, amazing food. So we enjoy ourselves here. This is where we live now. Winnipeg is known by its extreme winter, right? In 2013, we actually got a winter where it reached -55 and it stayed there for a few days. So if one day you want to see cold weather, just come here and you'll enjoy yourself. Let's go and talk about technology, or go straight to the topic we were asked to discuss, and that is the Cbct scan. So I started using the Cbct scan full-time in private practice 6 years ago. And I can guarantee you all, it changed completely the way I practice my daily clinic. The Cbct in endodontics is not seen, at least in North America, as a supplemental tool, but as an essential tool in the root canal treatment. As I discussed, I am going to try to discuss a little bit of scientific evidence, which I think it's extremely important, because I want to tell you that every piece of information I'm giving you, there's a scientific evidence for that. I'm not just saying out of the blue, but it's also important for me to share my clinical experience and show you that whatever I'm doing in private practice is in agreement with what I'm reading in the scientific journals. If you go back in time, in 2010, we would see approximately 86 papers on Cbct scan and endodontics. That wasn't a lot. 9 years from now, 2020 hasn't finished. In 1 year, you see 277 papers related to the topic of Cbct and endodontics. So it increased 3 times just in 1 year, right? When compare those two, the amount of scientific evidence that we have related to this technology. So it is a reality, and we have to adapt to that reality. And the quicker you get on board, the better it's going to be for you and for your patients. Any technology, when it starts, we have the innovators, the ones that start, the ones that are out there putting themselves at risk and see what's going on. I'm certainly not one of those. Then we have the early adopters, the one that actually believe that technology, believe those innovators and start using. After we have a few scientific evidence out there and we have already a sound evidence, we have the early majority. That's where I see me. And I think I started early, not an early adopter, but I was actually pretty early in adopting this technology. My opinion, those that are going to start using the Cbct now are either in the late majority or are seen as laggards already. This technology is here to stay, and it has been proven with scientific evidence and with our clinical experience. This is the machine. So I have this in the practice, and the patient goes, it's just like a panoramic radiograph. It just goes around your head. And you're going to get that 2D image. That raw image is going to be processed in a computer system, and it's going to give you those 3 different planes where you can play with it in order to see that 3-dimensional object in a 3-dimensional view. Our CBCTs, our computer tomography is different than the medical computer tomography. We can't forget that. The medical computer tomography has a fan beam geometry, and it has a huge amount of radiation. If you have a CT of your head, it gives you around 2,000 microsieverts around, while our cone beam geometry, our cone beam computer tomography is much more focused to a limited field of view. So the amount of radiation is much, much, much less for the patient. We will discuss this in a second. A survey regarding cone beam computer tomography in the United States showed that 50% of the endodontists in the United States have a Cbct scan machine in their office. 50%. And this article is from 3 years ago. This number is higher, I'm absolutely certain. The other 49% were either sharing Cbct scan machines with other offices or were referring patients offsite in order to get those images. But the majority of the endodontists are using this technology on a regular basis. So if you're a specialist in endodontics, if you practice endodontics on a regular basis, I have no doubt that this technology has to be soon incorporated into your practice. We have several position statements. We have one from the American Association of Endodontics together with the American Association of Oromaxillo-Radiology, one from the Endodontic European Society regarding the Cbct scan. I'm going to share with you all the position statement of the AAE because that's the one we follow here. And it's interesting because if we jump to the paragraph number 2, you're going to see that it says that Cbct, as any other technology, has its limitations. We're going to talk about that, including a possible higher radiation dose to the patient. I agree. Third paragraph, it says that it should only be used when the patient's history and clinical examination demonstrate that the benefit of this technology outweighs the risk. That means radiation. But it's funny because if you look at the first paragraph, it shows that it actually states that our radiographs, our periapical radiograph is a two-dimensional representation of a three-dimensional anatomic structure. And it shows that that image is compromised and it may demonstrate errors. So in my opinion, just this first paragraph shows you how much benefit you get of a 3D image and how much it outweighs the potential risk. When we talk about risk or fear, for sure, what comes to the patient's mind and to our colleagues' mind is dose consideration. Well, I want to let you know that it's pretty safe, the dose when it comes to dose. And I want to share with you this nice table here from Gary Carr, Academy and Schwartz textbook. And it shows the radiation. Look at that. If you're using, and this varies a little bit depending on the machine you're using, but if you're using a Cbct Scan machine from Kodak and you're doing a focus field of view on the anterior region, you're actually, the radiation dose, the effective dose is 4.7 microsieverts. If you're using the same machine for the posterior maxilla, now we're talking about 18.8 microsieverts. Look how interesting. When we used to do 4 bite wings as a routine procedure, we were radiating the patient 38 microsieverts and we were fine. Look how different it is from the medical CT scan, where if you do a medical CT of the abdomen, for an example, it gives you like 10,000 microsieverts. We all can have approximately 50,000 microsieverts per year to reach the safety limit. Look how interesting. We're talking about 4 microsieverts and our safety limit is 50,000 microsieverts. Even if you add the background radiation, even if you have your flights going from one place to the other, it's going to be very hard for you to reach the 50,000 microsieverts. This piece of evidence, I think it's extremely important, from the American Association of Physicists in Medicine. And it shows that at the present time, epidemiological evidence supporting increased cancer incidence or mortality from radiation doses below 100 millisieverts, which is 100,000 microsieverts, is inconclusive. So look how funny. Anything below 100,000 microsieverts, you cannot say that you're going to increase cancer or any other disease process, mortality, or anything like that. So it is a very safe piece of technology. Again, the cone beam computed tomography, the one we use in dentistry, okay? We always have to weigh the risks and benefits. In this picture, as you all see, I'm the risk. These 2 big guys are the benefits. I mean, there's no doubt that the benefit of this technology outweighs the risk by far. The one in blue that you see there is a good friend of mine, Bruno Azevedo, the cone beam guy. He's the one that taught me everything I know about cone beam. And for sure, I encourage you all to find him on Facebook, Instagram, and follow him. He is the guy to talk and discuss the specifics of this technology. What is the limitation of the CBCT? There's no doubt that I think the major limitation is artifact, especially when we are working inside teeth that have posts, previous filling materials. Those teeth have materials that can have metal or metal substances inside that can create these artifacts, or teeth that are right beside implants. Depending on the Cbct scan machine you can have an increased amount of artifacts, which is going to make your interpretation a little bit harder. What is the recommendation? Well, in endodontics, what we do, we only use the limited field of view, the small field of view. It's a little bit bigger than a periapical radiograph. It's a 40 by 40. It gives you a better spatial resolution. It has less radiation for the patient and a smaller area for interpretation. So for us, this is important because you're liable for the image you get. So you want to be sure that you're dealing with anatomic structures that you're comfortable with. So once again, in endodontics, we don't need the medium or the large field of view. We only use the limited field of view for the purpose of giving a better care treatment for your patient. We know that diagnosis is a puzzle. And in my opinion, CBCT today, in my opinion, is that red piece you see there. It's what's going to link everything, and it's what's going to give us the best outcome possible for our case. Anas, are we okay? Can we? You guys can hear everything's going good?
Yeah, I can hear everything, and I agree with you with what you are talking about CBCT. It's a standard of care these days.
Awesome.
Right.
Good. I really liked your terminology. Standard of care. I agree with you 100%. I agree with you. And look at this piece of technology, a piece of literature, guys. This scientific evidence here, they showed a group of dentists, radiographs, and they discussed the treatment plan with the patient, with the dentist, and say, okay, what would you do for this case? And then they showed the same case, but with a CBCT image now, a three-dimensional image of that case. Look how interesting. The diagnosis changed in 42%. So imagine working with a piece of technology that's going to allow you to change your diagnosis, because now you can see more in 42%. That's pretty substantial. Another piece of literature showed what would they do in a case of retreatment? What would be the retreatment strategy for a specific case? They looked at general dentists and endodontists. And look how interesting. Before the CBCT scan, 51% of the endodontists said they would retreat a specific case. After they saw the CBCT scan, the retreatment went down to 38%. It actually increased the amount of extractions. So this piece of technology allows you to see so much that sometimes might save you time, might save the patient's time, because sometimes the tooth is not even salvageable, what we don't see. How many cases have we started working on, and in the middle of the case you said, well, I didn't see this, I can't finish. This is never going to work. Well, I could have seen this before. So it's very interesting how this changed. In this study, the CBCT scan changed the decision regarding the case in approximately 50% of the cases. So translating to our clinical practice, if you're not making use of this technology, you're probably indicating the wrong treatment to your patient in 50% of the cases, especially when it comes to retreatment. This is very important, okay? Look at this case. This case was referred to me because the patient was in extreme pain. You all can see here that there is a radiographic finding compatible with apical periodontitis on the supernumerary tooth. We all can see a supernumerary tooth here. The periodontist referred to me saying, look, just see if the lateral is okay, and I am going to extract the supernumerary tooth. I'm going to raise a palatal flap and I'm going to remove the supernumerary tooth. Before he did that, I decided to do a CBCT scan in order to see this interesting anatomy. And we can see the lateral incisor here. We can see the supernumerary here. We can see the lesion around the apical portion of the supernumerary. We can see here the crown of the lateral, the crown of the supernumerary. We can see the apical portion, the lateral over here, and we can see the apical portion of that lesion right around the apical portion of that supernumerary. However, when we look at these images, it might make sense to raise a flap and extract that supernumerary. However, if we look at the middle portion of that axial view, you will see that the supernumerary tooth is actually fused to the lateral incisor, which means that if the dentist raised the flap and extracted that supernumerary tooth, it would have been a disaster. Or he would have lost the tooth, the lateral as well, or there would be a periodontal defect forever. This is a young woman. Can you imagine how much that would affect her? You can see that her teeth are just perfectly beautiful. So the Cbct scan technology allowed me to change completely my treatment plan. So it's not extraction anymore. We're just going to treat that supernumerary. So I went in, I accessed, I shaped, I cleaned, disinfected, and I obturated the supernumerary tooth. So here you have the final radiograph, and here you have the same case 15 months later, where you see complete resolution of that periradicular disease. Patient, the lateral is still vital. The patient is happy, smiling, and no pain. We ended up publishing this case in the Journal of Endodontics, where we showed how the Cbct scan proved to be an invaluable information in order to avoid a disaster. That's the word we have to use, because that's what it would have been if someone raised a flap and tried to extract that tooth. So a multi-discipline treatment, the multidisciplinary approach for any case is super important, and use the appropriate technology in order to support your clinical decision. Another interesting case, patient came to the office with extreme pain. You could not touch that 17. I think that's the terminology, that's the number system you guys use as well. So the 17 is that second upper maxillary molar. So you couldn't touch that too. Just percussion, patient was in extreme pain. Biting, he was in extreme pain. He wouldn't sleep at night, throbbing pain. But the funny thing is, the cold test responded normal. He felt pain and he went away immediately, which raised a red flag. I said, that's weird. Look at the panoramic radiograph that was sent to me. Unfortunately, due to time constraint, we can't go through the whole panoramic radiograph, but look at this. We can't see a lot. The patient was referred to me with a panoramic radiograph, a bite wing, and a periapical radiograph. So look at the amount of radiation this patient had, and the dentist still couldn't figure out what was going on. So when I looked at this PA and the bite wing, teeth were beautiful, no decay, nothing, and the patient in extreme pain. I looked at this and I said, what is this dark line here? Is this a crack? What is going on? So I decided to, especially based on the fact that the patient still responds to the cold test, I said, well, we need to have a better look at this. So I convinced them. We did a Cbct scan of the case, and this is the three-dimensional reconstruction of that case. And look at that. This is what we call a dens evaginatus. It's extremely rare in molars, especially maxillary molars. So as you can see here, this groove that you all see here has a little pit that communicates with the furcation area. And what the patient had was a periodontal abscess. You can see the furcation bone loss. This is where the whole pain was coming from. That's why he could not chew on that side. Here it is. Look at the amount of bone loss. Look at the pit that communicates the oral environment with the furcation area. We can see here all three views showing how complex this anatomy was. So instead of going in, doing unnecessary root canals or treatment like that, the only treatment option, unfortunately for this case, is the extraction. There's no way you can treat that periodontal defect in the furcation area in a conventional manner. So this patient, unfortunately, due to that anatomical defect, ended up having an infection in the furcation area, and the tooth had to be extracted. Once again, without this technology, probably a few would have jumped in, did a root canal, the pain would still be there, it would never go away. And then when you decide to extract the tooth, how much time have we wasted? How much money has the patient wasted? And everyone ends up being frustrated. Another interesting case where it was referred with swelling on the lower teeth, didn't respond to cold. The dentist was like, look, you need to do the endo or the 43 and 44. This is not good. There's swelling. Patient came in with a radiograph. I wasn't very happy with the radiograph I saw. I saw images that I wasn't very comfortable with. The dentist said there was a radiographic finding compatible with a lesion of endodontic origin on the 44. I said, well, let's just take a scan and see if something shows up. And yes, when we took the scan, you can see expansion of the cortical plate, of the buccal cortical plate. You can see that that lesion that the dentist saw related to the premolar was actually superimposition of this radiolucency here. I usually tell the patient, sometimes I don't know exactly what's going on, but I can tell you what is not going on. And this is not an endo problem. For sure, this is not endo related. I referred her to an oral maxillofacial surgeon, and with no doubt, it came back that was an ameloblastoma. So again, imagine going in, doing a root canal on those teeth, and waiting, the patient suffering. How much would have that frustrated everyone at the end? So there's no doubt. What I like to make fun is if dentists without a radiograph are blind, dentists without a CBCT scan have only one eye. So we do need to see the whole picture. Vertical root fractures can be challenging, especially because vertical root fractures, they happen more on cases that have been previously treated in their buccolingual. So because of the amount of artifacts, it can be a little bit challenging to see those fractures, especially if they're very, very thin. When it comes to vertical root fracture, we have to take in consideration the whole picture. So we have to look at how is the probing depth, how is the clinical signs, sinus tract, dull ache, how long the pain has been there. So we really have to gather all those pieces of information in order to come up with an accurate diagnosis of vertical root fracture. Fuad has a beautiful study where he showed the 5 findings on a CBCT scan that were consistent when it was confirmed of a vertical root fracture. And I strongly encourage you all to read this article. And if you're looking at these 5 signs, and if they all match, for sure you have a vertical root fracture on that case. Unfortunately, again, due to time, I'm not going to waste too much time over here. But a crack, look at this. This was referred to me in the dentist. Look, I don't know what's going on here. The patient can't bite on that side. It hurts more on the 17, but I don't see anything on the periapical radiograph. I don't see anything wrong. So the same day, the same patient, the same tooth, I did a CBCT scan. Now it's pretty straightforward. We can all see the mesial crack here. We can all see a breakdown on the bone. Look at that, vertical bone loss on the mesial. We can also see that there's already a radiographic finding compatible with the lesion with communication with the sinus. So look how interesting. The CBCT scan did not only give us the right diagnosis, it showed why you have that problem, but if you're going to extract this tooth, wouldn't you want to know ahead of time that there is a communication with the sinus? You would be prepared for any complication, right? Vertical root fracture, look at this. This patient was referred the same thing. I can't chew on this side. A colleague of mine did the endo on that 36, and the patient was having trouble chewing on the 6 and on the 7. Based on the radiograph, we're like, okay, am I going to treat the 7 or am I going to redo the 6? And we stayed having this discussion like crazy until I decided, I said, you know what, let's just do a CBCT scan. When we do a CBCT scan, look at this coronal view. Look at this breakdown on the bone on the lingual aspect of the 6. Anytime you see this breakdown on the bone just getting away from the tooth, this is a red flag. Look at this image. I think when we see this axial view here, there is no doubt, there is nothing for us to discuss anymore. I mean, for sure, the pain is coming from that crack, from the fracture on the distal and mesial root, and that tooth has to come out. We could not see that on a radiograph. Maybe if you get the right tooth, you would jump in, you would start the retreatment. In the middle of the retreatment, you would see the fracture. Why make the patient go through all that if you can already see everything ahead of time with a CBCT scan? So A thorough dental history is extremely important. Signs and symptoms such as pain, swelling, sinus tract, a deep, narrow pocket, all those signs and symptoms are extremely important for us to diagnose a vertical root fracture. Preoperative, like I showed you, it's extremely important. Look at this. This is another interesting case where you look at this radiograph and you say, okay, that's just pretty straightforward. We can see that the apex is really wide, but I can get a big gutta percha, or I can just roll gutta percha. I'll be able to seal that. If you take a Cbct scan, here you go. You have the same case. You might tell me, look, I don't see any difference in that Cbct and the radiograph. For me, it's very similar. Nothing added to my treatment plan when I look at your Cbct scan. Well, what about if I show you another view like this one? Does that change a little bit the way you see your case? How would you fill this case? Look how large this is. Look on a mesodistal view how large this is. Where is your working length? Is this your working length, or here is your working length? Where would you stop your obturation? So this is an extremely important technology in order to prepare you for the case so you don't get caught by surprise. Another one where the patient came, oh, I perforated this tooth. The dentist referred to me, I perforated the apical portion. We all know that a perforation at the apical portion is not that bad. As the farther you go apically, the better it is in order to avoid contamination. So in this case, maybe it might be worth saving. But again, let's do a Cbct scan of this case and look how interesting. Yes, we can see the perforation, yes, but I can also see a vertical bone loss on the distal aspect of this tooth, which I could not see on the radiograph. Not only that, I can also see that the mesiolingual canal has a strip perforation. So just with that, vertical bone loss on the distal aspect and that the strip perforation on the mesiolingual, now how is our prognosis? Is it better to go with endo, or is it better to throw the towel and go with an implant? So why not know all that ahead of time, okay? When it comes to internal anatomy, I tell everyone that Cbct scan is just like a GPS. When you go driving somewhere, you don't start driving and then you turn your GPS. You turn your GPS and follow exactly where he shows you to. When it comes to internal anatomy, it's the same thing. Everyone knows that maxillary molars have 4 canals. That's a no-brainer. First maxillary molars, 90% of them have 4 canals. So I don't take Cbct scan to check the MB2. I use a Cbct scan to show me when that MB2 is not there in order to avoid me to remove too much tooth structure. Like this case, the dentist started, he couldn't find the MB2, he referred to us, and there's no doubt he couldn't find the MB2 because there was no MB2 on this tooth. This tooth had only 3 canals. So isn't it much better to know that before you jump in the case and start the root canal treatment? Or this case, where the dentist said, look, I don't know, I'm trying to find the MB2 and I can't. But when he referred, the dentist that did the previous treatment actually found the MB2. The canal that they didn't find was the MB1. So it's interesting that the MB1 wasn't found, the MB2 was treated, and the dentist was removing tooth structure to find the 4th canal. So then you perforate the tooth and you're like, why didn't I see this before? So again, turn your GPS before you start the treatment and not in the middle. Cases that are seen as straightforward and simple, when you actually take a close look with a 3-dimensional view, you see that they're not that simple. In this case, you don't only have 2 mesial buccals, but you also have 2 distal buccals. Isn't it better to see this beforehand? So when you look at all the different views, you can clearly do your access, find all the canals, and at the end, here you go. You have all 5 canals obturated. Even that little lateral canal that we saw here was obturated at the end. The 3D reconstruction showing all the canals obturated, and here's the final radiograph. Oh, come on, that's very rare. Well, not as much as we think. Look at another upper molar the same way. Let's take a look in a different perspective. And here it is. You have two canals in the mesial, 2 canals in the distal, and 2 canals in the palatal. There it is. The palatal canal splits in 2 over here, 2 mesiobuccal roots, canals, 2 distal buccal canals. So at the end, when you look at the CBCT scan, you see all those different branches obturated. But how much we would have missed if we haven't seen this beforehand. So there's no doubt, guys. Remember this, turn your GPS before you start the treatment. That is the best way to get a great outcome, okay? We ended up publishing a study in the Journal of Endodontics a few years ago, showing that even though it's a rare variation, the presence of the second distal buccal canal, it is there sometimes. Look for it, especially if you have this technology, you're gonna see that it's there much more often than what we think, okay? Mandibular molars, what I wanted to highlight is today we all discussed the presence of that middle mesial canal. So it's that little canal right in between the mesiobuccal and mesiolingual. Now, is it there a lot? Maybe 20% of the cases, but wouldn't it be better to know this before we even start? So cases like this, when you take the CBCT scan, it shows you that there is a presence of that third canal in the mesial root. When it gives you that assurance, it's going to give you more confidence to gently trough that area and find that third canal. So very important, know your anatomy before you start. And then it becomes easier to find those canals, negotiate. And look at this. This one had 5 different portals of exit. So if you missed one, probably you would have failure for sure. Okay? Microscope is very important. We all know that. So it's not only the CBCT, use magnification and illumination is extremely important. Sometimes in the middle of the treatment, I use the CBCT like this. If you're starting a calcified canal and you're going in and for some reason you say, uh-oh, I don't know, I can't find this canal. There's something wrong here. So stop what you're doing, take a CBCT scan, and the CBCT scan is going to show you where you were going and where the canal is. Then gently you can just go there and redirect yourself. So why not stop in the middle sometimes and just redirect yourself in order to get the best outcome possible without removing too much tooth structure? How many cases have we done that we destroyed the whole root in order to find that canal? Retreatments. Retreatments is important, not only, like I said, for the anatomy, but now, I don't know what your protocol is there, but here we do a lot of the selective root retreatment. With CBCT scans now, we can actually identify where the pathology is coming from, and we are going to selectively retreat only that root. So for an example, upper molars, where we know that the major cause of failure is the missed MB2, when we do a CBCT scan image and we identify that the distal buccal and the palatal root is fine, we just go in and we retreat the mesiobuccal root. Less invasive, cheaper for the patient, okay? So we are only gonna focus where the problem is. Beautiful root canal, but our colleague missed the MB2. So what did I do? I just jumped in that crown, specifically in that mesiobuccal root. I found the MB2, I retreated the mesiobuccal root. Here you see all 4 canals obturated. 1 year later, completely healed, no pain at all. So for surgeries, it is paramount. I cannot even think about doing a surgery if I don't have a CBCT scan. Look at this case, guys. Pretty straightforward. Surgery, small tooth, calcified, new crown. I don't want to lose my crown. Probably surgery would be the way to go. So I said, okay, let's do a CBCT scan technology here, the CBCT scan image, and look at this. We can all see that little small part of the canal at the apical portion, and we can also see that lesion of endodontic origin there. That's a no-brainer. I wish I could interact with you all just to know if you all could see something else. Is there something else jumping to your eyes when you see this image? When we look at this, if we focus too much on the tooth, we will miss this. Actually, this patient did not only have an endodontic problem, but this patient also had a nasopalatine duct cyst. Imagine doing the surgery without seeing that this is actually a cyst. The problem in this case is you could either miss it and the cyst would still be there, or break into and the hemorrhage would be tremendous. So why not know this beforehand? And when you do your surgery, you're already prepared. You do your palatal access as well. And here is the pathological examination showing that it is a nasopalatine duct cyst. So why not know this before I jump in and do the surgery? Traumatic injuries. If you look at the IADT guidelines, it says that you need several projections and angulations when there's dental trauma. You need a straight shift, meso shift, distal shift, sometimes occlusal. So much radiation where even with all that, sometimes you still don't know what's going on. And why not just go in and do one CBCT scan image, a focus field of view, and get much more information. We do not want to miss, for an example, root fractures or alveolar fractures. So this patient was referred to me due to a hockey accident. He got hit by a puck. You know that hockey is very popular in Canada. So this patient was stitched up and everything was put together by the emergency dentist, the oral maxillofacial surgeons, and they sent it to me for us to take a look at the root canal. And they said, don't worry, everything is in place. Probably there's no fracture of the bone. But interestingly is that when I did that CBCT scan image that I talked to you all, and I looked at those teeth in a three-dimensional manner, I could see that the teeth were not exactly in the same position, which is normal. It's very hard to put those teeth back there. But it wasn't diagnosed an alveolar fracture, a palatal alveolar fracture. Here you go. It is there. So look at the amount of information I got from just a small focused field of view. This changes completely how much time you're going to leave the splint there and how much more you get with just a focused field of view. Horizontal root fracture, the same thing. Patient comes, everything's testing normal, no treatment. I did nothing. Patient responds normal. Look at the 3 months follow-up. Look at the 6 months follow-up, 9 months follow-up. Look at the apical area, how it's developing. Look how it's narrowing the walls a little bit. Look at 18 months and 2 years. The CBCT scan showed complete healing of that horizontal fracture. So it's a beautiful healing without us even having to touch the tooth. So sometimes, what's the lesson from this case? Sometimes the best treatment for your patient is no treatment, especially if he's responding normal to our endo tests. Resorptive defects, it's interesting because the CBCT will show us where exactly the resorptive defect is located. So with a radiograph, we're always like, okay, is it buccal? Is it palatal? Let's do different angles. Where with a CBCT, you know exactly the extension. You know if there's evasion of the pulp. You know if it's buccal, if it's restorable or not. So I can't stress more how important it is to turn on the GPS before we even start the treatment. You can have cases like this where the scan, the only thing that shows you is that this tooth is not restorable. Why am I even going to try when you see the resorption going up all the way almost to the apical portion of the tooth? So I don't need to be a hero anymore. The CBCT showed me, look, there's nothing you can do. Invest your money on an implant that you're going to be much better off. Or cases where the resorptive defect is so small, you don't even need to do a root canal. Just repair the resorptive defect. Buccally, just raise the flap, repair the defect, and that's it. So treatment planning is completely changed depending on what you see on a three-dimensional image. Or cases where it could have ended up as a disaster as well, where patient was in extreme pain, too cold. We decided to take a CT scan because we were looking at those lesions on the first molar as well. But look how interesting. The CT scan showed this huge resorptive defect. I don't know if it's a resorptive defect or if it was damaged when the wisdom tooth was removed, but look at this. Imagine the distal buccal root has a huge resorptive defect. Imagine putting your needle in this canal and irrigating with sodium hypochlorite. Can you imagine where the accident that you could cause? So in this case, I decided to obturate the distal buccal root with MTA. That was the only thing I did. Gently irrigate it without having the risk of accident. So it's much better to know that before, and instead of going and having the accident and say, well, I couldn't see this on a radiograph. Now we have the technology that allows us to see this before we start. Outcome assessment. So when you see a case like this, 10 years later, look at the lesion here. 10 years later, everyone was happy. It healed beautifully. Everyone is happy. Well, when you take a Cbct scan, you will see that it did not heal beautifully. So we actually have pieces of literature showing that there is a discrepancy between what you see on a radiograph and what you see on a scan. The amount of apical periodontitis that you see on a Cbct scan is much higher than what you see on a normal radiograph. So the take-home message here is we might not be seeing if the cortical bone, the buccal and the lingual or palatal cortical bone is intact and the lesion is small, you might not see it on a radiograph. That's why a Cbct scan is valuable as well, not only to diagnose, but also to assess your outcome, where sometimes we say, okay, it healed, you're great, but when you take a scan, no, it hasn't healed completely yet. It's an incomplete healing. So that might also become a standard of care for us to evaluate outcome as well. Several studies showing that there is, even between endodontists and radiologists, the amount of lesions seen on a PA is smaller than what we see on a Cbct scan. So we do have the scientific evidence to prove that, okay? So the future, in my point of view, is here now. This is the future. Today, we have to incorporate this piece of technology. There's no doubt. And it will change your clinical decision. It will help you navigate that case in a smoother manner. And it will help you evaluate your outcome as well in a more accurate manner as well. So, Anna, thank you very much. I hope this is exactly what I mean. I am very grateful to be here. Thank you for having.
Yeah, thanks a lot, Professor. Thanks for what you are writing in Arabic for colleagues. That was a very informative lecture, and you detailed several cases. Really, it was highly documented and full of informatives. I wonder if we can ask some questions, please.
Absolutely.
Yeah, okay. First of all, Professor, thanks for that great, amazing lecture, amazing cases. The documentation you do is something unbelievable. One of my colleagues, Mazen Doumani from Saudi Arabia, he sent to me by WhatsApp that your lecture is really something unusual. We have some questions. The first one, up to our country.
Unfortunately, the lecture is longer than that. There's much more. I just summarized. If one day we have time, it's endless, the amount of things. But thank you very much.
We have some questions. The first, you know, Professor, in my country, we cannot get the newest editions of the Cbct machines. For example, the most updated device in my country is 2015, I think, when we discussed the year. So does the generation affect the accuracy of the Cbct? For example, your photos are something special, especially the longitudinal fracture. We can see the longitudinal fracture. We can see the split. We can see the location of what we need in the Cbct. In my country, I feel sometimes I cannot get the accuracy that you have in your presentation. Can we use another software, or what we can use and advise from you?
Great question. I use several different machines. I already used the Kodak Airstream. I used the Sirona. I used the J-Morita. I like the J-Morita. Today I'm using the X800, amazing piece of machine. I was using the old version before. I haven't seen a huge difference between them. So if you have a J-Morita from 2015, 16 or 15, it should work fine. The X800, the only thing that allows is to get the image in a 360 manner, so it creates less artifact. But you mentioned something very important, knowing how to use different softwares and different, you can work with the software in different settings that will allow you to see that fracture. One tip that I can give you, Anas, is if the patient comes and you think there's a vertical root fracture, load the tooth when you're taking the exam. Ask them to bite on something. So they bite on something, and
that's right.
Or like a piece of wax, a hard one, where they're gonna bite on it, and then you do the scan. It will help split a little bit more, so then you'll see the image. That might be a good idea.
Because you are trying to make a small separation between the parts of the fracture. Professor,
filters. There are several filters that you can use as well.
Yeah, the other question, do we can rely on CBCT on the field of research, for example, when we are measuring the gap between a crown and the root, when we are measuring the adaptation, or you push forward for nano CT or CBCT for small samples? Because sometimes in researchers they use CBCTs in measuring, for example, the change, the gap, what we call it, the fitness of the crown or the post.
Yeah, you just have to watch out. Depending on what you see, there's lots of artifacts there that can give you that ghost image, that phantom image. In my opinion, to look at something so minute, a micro CT scan is how you should go. So you have to use another technology. It's a micro CT scan. Those are the ones that, in my opinion, would be more accurate for that.
Yeah, that sounds great. I did my research by the micro CTs, and I get the information that I need. That's right. But I'm wondering that if new generations can give this point of view or the method to get more information from
unless you have a specific filter that will allow you to remove those images, that little artifact, that could. But
Professor, in the last week I was doing a lecture about guided endodontics. Guided endodontics. The guided endodontic rely on the CBCTs, but sometimes I feel that something hard if we try to do some good stability of the guided endodontic material of the guide. When we try to match the scan and the CBCT and put the guide in endodontic, any half or 1 millimeter moving will affect the result. Do we really have a brave position, or can rely on guided endodontic by the new CBCTs devices, or what's your advice?
We can. The only problem with the guided endodontics, you need the large field of view. The small field of view, so you need the large field of view in order to get the most reliable guide. So for an example, I can't do it because my machine only gives me the limited field of view. However, having said that, in my opinion, when I work with my CBCT scan, especially for surgeries and things like that, I really don't need the guide at this point. I know several that are used. The guided endodontics has been starting there. It's almost like a trial mode at this point. They have other technologies coming aboard, but they're still working on it. I don't think it's 100% reliable at this point. I agree with you. Because in endodontics, 1 millimeter out, and you're going to be completely
will end with perforation or something disastering the case.
So I know that for surgery, you need the large field of view in order to get the appropriate guide. But I don't have a lot of experience with guided endodontics at this point. I think it's still in a very initial mode. We need to have more studies and more experience with that.
Professor, thank you a lot. And on behalf of the student and the staff, on behalf of the dean from this holy place, we really thank you a lot. And we hope if you accept the invitation for another lecture, like 1 month after now, for the irrigation and the new technology, new trends in irrigation. You suggested that topic for me by the email. I wonder if you have time to give us another opportunity. I really, on behalf of my colleague, by my heart, I thank you a lot, Professor. Thanks a lot for this participation, this informative lecture. You did something great for us. Thanks.
We'll figure out a date for sure. Thank you very much, guys. Thank you for having me.
Thanks. Bye-bye.